MR pulse sequences था तो
Yeah,
change हो
but
गया है?
no, this we have to finish because otherwise you will miss on the basic principles, no? There is no point in not understanding this and going ahead with that topic. That's why I'm taking this.
Okay, ma'am.
Okay. So we know that a magnetic nuclei has a magnetic moment, and non-magnetic nuclei does not have that, and that is the property which we utilize for magnetic resonance. So the MR active nuclei is based on spinning motion of particle and specific kind of nuclei present in biological tissues. These are called MR active nuclei. Proton has got its spinning properties. So list of MR active nuclei are hydrogen, carbon, nitrogen, oxygen, fluorine, sodium, phosphorus, etc. So there is electric charge on the surface of the proton, thus creating a small current loop and generating a magnetic moment mu. So what is the electric charge on a proton? Anyone?
Positive.
Yeah, there is one positive charge on a proton. So this when if this electric charged, positively charged proton spins on, then there will be a small current loop generated with a magnetic moment mu. So thus proton magnet differs from the magnetic bar in that it also possesses angular momentum caused by spinning. So that is the basic difference between a conventional magnet and a proton magnet. It has a angular momentum caused by the spinning of the proton along its axis. So hydrogen proton are MR active nuclei having largest magnetic moment, greater abundance, best for clinical utility. Protons has tiny bar magnet and odd number of protons. So these are the advantages of hydrogen as an MR active nuclei. And alignment process, when there is no external field, these magnetic dipoles or the hydrogen nuclei are randomly aligned as shown here. The direction varies. And when an external field is applied, then it gets aligned with the field. Here you can see that from the previous image where it is not aligned. So here it got aligned. That doesn't mean that it will spin towards the same direction. It can be, it just get aligned with the magnetic field. Protons in magnetic field, so low energy H plus aligned parallel to the applied magnetic field, the spin up nuclei, and high energy H plus aligned anti-parallel to the applied magnetic field. The spin up and spin down, that is what we have seen here. So you can see here some of them are spin up and some of them are spin down. So that is depending on the energy of the nuclei. So low energy ones will be parallel to the applied magnetic field, and high energy ones are anti-parallel to the applied magnetic field. The spin up are low energy ones and the spin down are high energy ones. Another terminology is precision, spinning of NMB around the applied magnetic field B0. So proton spin its own axis. If some body hits, it start to wobble. Start to precess in a path called precisional path, and precisional frequency is the precision per unit time, which is expressed in mHz, megahertz. The proton wobble, spinning protons wobble about the axis of the external field. So frequency of precision is the resonance frequency it depends on the strength of the magnetic field. So this is another pictorial representation of how the spinning takes place. So precision, you can see the precisional path, magnetic moment of the nucleus, and the proton wobbles about the axis. So this is the precessional path the magnetic dipole will follow, and this is the magnetic moment direction, and there is the proton wobble about its axis also. And the Larmor equation, the precession speed of proton can be measured as a precessional frequency, depends on magnetic field strength, precessional F. We can calculate the frequency by using the equation called Larmor equation, W0 equal to RB0, where W0 is PF in Hertz, precessional frequency in Hertz or megahertz. B0 is the strength of the electric magnet field, which is measured in Tesla, and R is the gyromagnetic ratio. So the RF pulse is the radio wave. It is an electromagnetic wave and a short burst of pulse, which is called RF pulse. We need a special RF pulse that can exchange energy with protons. Energy exchange is possible when protons and RF have the same frequency. So energy transformation is possible and protons jump to a higher state. So apply RF pulse at resonant frequency, then protons absorb the energy. So we have seen that we have RF pulse generators. So this RF pulse needs to be in the same frequency as the proton so that the energy transformation is possible. So if the RF pulse is applied at the same frequency, then the precessional proton gets some energy. From the picture you can see that if the person holding the bucket and the boat is moving at the same speed, then he can collect the water, and if it is not, then he will not be able to collect the water. It is as simple as that. This is another pictorial representation of it. So what goes up must come down. Energy is retransmitted as RF signal. We have seen that there is an RF transmitter and an RF receiver. So whatever the energy received by the proton, that is retransmitted as an RF signal which we detect. And resonance is re-emission phenomenon when an object is exposed to an oscillating perturbation that has a frequency close to its own natural frequency of oscillation. So this is when an object exposed to an oscillating perturbation that has a frequency close to its own natural frequency of oscillation. So nucleus is exposed to an external perturbation that has an oscillation similar to its own natural frequency gains energy. Resonance is a phenomenon whereby an object is exposed to an oscillating perturbation that has a frequency close to its own natural frequency of oscillation. If the energy is delivered at exactly its precessional frequency, which can be calculated by Larmor equation. So result of resonance. So you can see here the transverse plane and the longitudinal plane, and the NMV, it gets flipped. And the flip angle is 90 in the transverse plane when the magnetic field is applied. Where the NMV was here, it gets flipped, and the flip angle becomes 90 degree when the applied magnetic field, with the applied magnetic field. So this is another pictorial representation of the resonance. Energy at 90 degree at B0 and the precessional frequency is what is called resonance. And this is a condition necessary for resonance. So here you can see the magnetic resonance pulses and the tissue and the signal which we get. So the pulses are going inside, it passes through the tissue and we get a signal. So the resonant or Larmor frequency is determined by the nuclide and the field strength and the molecular structure. So result of resonance are flip angle, phase, MR signal, free induction decay, which is abbreviated as FID, relaxation, T1 recovery. So flip angle, the NMV moves out of alignment away from B0 is called flip angle. So magnitude of flip angle depends upon the amplitude and duration of RF pulse, and usually the flip angle is 90 degree when the magnetic field is applied. We have seen this. When the magnetic field is applied, it gets flipped to the 90 degree to come across the transverse plane. And phase is the next quantity. So the NMV moves into phase with each other. The phase is the position of each magnetic moment as the precessional path around B0. Two types, one is out of phase and two in phase. So when the magnetic dipole is applied or the magnetic field B0 is applied, some of them get out of phase and precession around B0, and some of them will be in phase in the precession around B0. So these are called the phases of magnetic movement. You can see with the in phase movement and here the out of phase movement, where each one is at different positions in the first row. The magnetic net dipole net magnetization is at different phases, and here you can see that all are in same phase. The MR signal, if a receiver coil is placed in the transverse plane, a voltage is induced in the receiver coil when in phase, and magnetization cuts across the coil and produces magnetic field fluctuations inside the coil. Therefore, NMV persists at the lambda frequency in transverse plane. A voltage is induced in the coil. It constitutes the MR signal. So the flip takes place when the applied magnetic field is applied and the net magnetization vector flips to the transverse plane and the receiver coil is placed along that, and we get the MR signal. FID is when the RF pulse is switched off, the NMV is again influenced by B0 and it tries to realign it. In order to do so, NMV must lose the energy given to it by the RF pulse. As relaxation occurs, the NMV returns to realign with B0. So during relaxation, the NMV gives up absorbed RF energy and return to B0. The magnetic moments of NMV lose transverse magnetization due to dephasing. So relaxation results the recovery of LM is caused by a process termed T1 recovery, and the decay of TM is caused by a process termed T2 recovery. So this is what actually the whole principle is based on. When the RF pulse is switched off, when the magnetic flux is applied, it gets flipped and it gets aligned with the transverse plane. And when the RF pulse is switched off, it again influenced by B0 and it tries to realign it. In order to do so, it must lose the energy given to it by the RF pulse, and as relaxation occurs, it returns to align with the B0. So the recovery is caused by a process termed T1 recovery and the decay is caused by the process termed T2. How the signal intensity varies with the time. So you can see that as the time passes, the signal intensity decreases. Recovery of magnetization in the longitudinal plane with loss of absorbed RF energy is the process T1 recovery. Recovery of magnetization in longitudinal plane with loss of absorbed RF energy. So that is T1 recovery, and decay of magnetization in the transverse plane is the T2 recovery or T2 decay, sorry. So we have two terms, T1 recovery and T2 decay. T1 recovery is recovery of magnetization in the longitudinal plane with the loss of absorbed RF energy, and T2 decay is decay of magnetization in the transverse plane. You can see that both are interrelated to each other. So excitation along the longitudinal plane, and then it come back to transverse by losing its magnetization, losing its RF pulse energy. uh, it come back to the transverse plane. So this is another example of the same thing. In the longitudinal direction and in the transverse direction, the magnetic dipole rotates around that with application of RF pulse in the same frequency as the precisional nuclei. So we have seen all this. So when the magnetization is applied, the magnetic dipoles get aligned along the magnetic field, applied magnetic field. It can be spin up or spin down. When the RF pulse is applied, it gets wobbled and it starts spinning, and then once the RF pulse is off, then it starts losing the RF, the energy absorbed, and the effect of the magnetic field comes predominant. And that is how when it loses that energy, we get the signal. The RF pulse relaxation results in T1 recovery of the magnetic field strength and decay of the magnetic field RF signal strength. That is T2 decay. T1 recovery is caused by nuclei giving up their energy to the surrounding lattice. It is often termed spin lattice relaxation. The rate of recovery is an exponential process with a recovery time constant called T1. This is the time it takes 63% of the LM to recover in the tissue. So this is the you can see that it is recovering, and 63% of it is reached the time, that is the T1 recovery time. Longitudinal magnitude and the time. So 63% of what it is getting back, that is the T1 recovery time. Just a second.
Hello, ma'am.
Yes, we'll continue. So depending here you can see depending on the intensity of the signal, we have either short T1 or long T1. So when the intensity is higher, we get a short T1, and when the intensity is smaller, we get a long T1. So that this gives rise to the T1 weighted image. And T2 decay is during the relaxation, the magnetic movement of the NMV loss transverse magnetization due to dephasing. The relaxation results in decay of magnetization in the transverse plane. The decay of transverse magnetization is caused by a process termed T2 decay. It is often termed spin-spin relaxation and results in decay. So T2 relaxation results in loss of transverse magnetization due to interaction the magnetic fields of adjacent nuclei, and a signal or voltage is only induced in the receiver coil if there is a magnetization in the transverse plane. So here you can see according to the T2 weighted what is as a T2 weighted image. With high intensity we get long T2 and with low intensity we get short T2, resulting in the T2 weighted images. And pulse timing parameters. Pulse sequence is a combination of RF pulses, signals and intervening periods of recovery. The pulse sequence consists of several components. TR is the repetition time. It is the time from the application of one RF pulse to the application of the next and is measured in milliseconds. TE is the echo time. It is the time from the application of the RF pulse to the peak of the signal induced in the coil. So measured in milliseconds again, T controls the amount of T2 relaxation that has occurred. And AT is the time of acquisition time. So TR is repetition time. So the time from one application, one pulse to the next pulse. And echo time is the time from the application of the RF pulse to the peak of the signal induced in the coil. And AT is the acquisition time. So here you can see all basic pulse sequences TR and TE. So TR is one pulse applied to the next pulse applied. The beginning of RF pulse 1 to the beginning of RF pulse 2. And TE is the from the application of the first RF pulse to the peak of the signal. Beginning of the RF pulse to the peak of the signal. So that is echo time. So the repetition time or TR is the time interval between applications of two RF pulses measured in milliseconds. Determine amount of relaxation allowed occur between two RF pulses and determine the T1 relaxation. Echo time is the time between application of RF pulse to peak of signal induced, measured in milliseconds again. Determine the amount of transverse magnetization decay allowed to occur before the signal is read. T controls the amount of T2 relaxation. So here you can see the amount of transverse magnetization decay allowed to occur before the signal is read. So here is one T2. This is T2 star, like from one signal, like from 90 degree and 180 degree. So from up to 180 degree, the T2 star takes place. And if you look at the whole signal process, that is the T2. And this is the T2 star. So the applications of TR and TE. So long TR it up to 2000 milliseconds, short TR 250 to 700 milliseconds, long TE is around the order of 60 milliseconds, and short TE is the order of 10 to 25 milliseconds. So here is a table of or a matrix of TR and TE with T1, T2 and pulse decay. So TR T1 short and TRPD long, TRT2 long and TET1 short, TEPD short, TET2 long. T1 versus T2 imaging. The T1 weighted images are short TR and TE, black fluid, CSF, urine, etc. and white fat, anatomical details, high SNR, signal to noise ratio, CET1 for pathology. And T2 weighted images have long TR and TE, white fluid, relatively black fat, detect pathology, and the H2O signal will be in alignment with the applied signal. So here is a measure of T1 and T2 in tissues at 1.5 Tesla MRI. So tissue, muscle, skeletal tissues, heart, etc. T1 is of the order of 870 milliseconds, skeleton and heart. And T2 is the order of 47 for skeletal and 57 for heart. So liver T1 is 490, T2 is 43.
Is Chandni Chowk. Change here for Old Delhi station of the Indian Railways.
Kidneys, T1 is 560 and T2 is 58. Spleen 780 and T2 is 62. And adipose tissues, T1 is 260 and T2 is 84. And brain grey matter, T1 is 920 milliseconds and T2 is 101 milliseconds. And white matter 790 T1 and T2 is 92. So this is what enables us to how to distinguish between two different things. The contrast, what we say in X-ray imaging, and this is what gives us the contrast in the MRI imaging. And quality of the images, it is controlled by many factors: signal to noise ratio SNR, contrast to noise ratio CNR, spatial resolution, scan time. So image contrast in MRI tissue discrimination is better as comparing to other modalities. So you know that if we want to find better tissue delineation to identify between different tissues on a better way, we need to have an MRI scan. That is not possible in CT scan or X-rays. You know that we can differentiate between bone, air and tissue, but not much between tissue and tissue. So that is better in MRI. Image has high contrast if there are areas of high signals, white on image, low signal, dark on image, intermediate signal, shades of gray. Tissue contrast is different for fat, CSF and muscles. That is not the case in other imaging modalities. Signal to noise ratio. So the signal is the voltage induced in the receiver coil by precision of NMV in transverse plane. Noise, the noise is generated by the presence of patient in the magnet. And signal to noise ratio is the ratio of the amplitude of the signal received to the average amplitude of noise. Increase the signal, increase the SNR. And the contrast mechanism can be obtained as T1 recovery or T2 decay or proton density, which is represented as PD in the table. And magnetic resonance image, you can see the T1 proton density, T2 images. So we have seen that what will be white, what will be black, it will be reverse in the T2, and the tissue characteristics can be identified by these features in the magnetic resonance image. So we can get a better contrast among tissues to have a clearer idea of the disease condition or the normal situation. So T1 recovery in fat occurs due to the nuclei giving up their energy to surrounding. Slow molecular tumbling in fat allows the recovery process in fat is rapid. So T1 time of fat is short. So if the giving up the energy and the molecular tumbling, the recovery process is fast. So the time required for that is short. So here the T1 recovery in fat, you can see that um, the 90-degree flip happens and then it recovers and fat regains longitudinal magnetization rapidly. So you can see that in the previous picture that 63% was coming like that. Here it is reaching the reaching to a higher value faster in shorter time period. T1 recovery in water occurs due to the nuclei giving up the energy acquired from the RF excitation to the surrounding lattice. In water, molecular mobility is high, resulting in less efficient T1 recovery. So T1 recovery of water is longer, so T1 time of water is long. So this is what again the 90-degree flip takes place and the water vector relaxes and the water regains longitudinal magnetization slowly. Here the curve is more flat compared to here. It regains its maximum value faster. T1 contrast, T1 time of fat is shorter than water. Fat vector realigns with the applied magnetic field faster than the water. Longitudinal components of magnetization of fat is larger than water. So T2 decay in fat, it occurs as the result of magnetic fields of the nuclei interacting each other. Energy exchange is more efficient in the hydrogen in fat. The T2 time of fat is short, around the order of 80 milliseconds. So that is what is shown here. The 90-degree flip takes place. The fat vector decays and the time the fat loses transverse magnetization rapidly. It comes down faster, comes down to a lower value in a shorter time period. So T2 decay, energy exchange in water is less efficient than in fat. T2 time of hydrogen in water is long. T2 time of water is around 200 milliseconds. And T2 contrast, T2 time of fat is shorter than that of water. And transverse components of magnetization of fat decays faster and water has high signal and which appears bright on the image. On T2 contrast image, fat has low signal and appears dark on T2 contrast image. So you can see that here the fat vector in phase and fat vector dephases quickly. It moves faster and here you can see that it moves slowly. So you can see that it is coming down with a longer period of time. Water loses transverse magnetization slowly and here you can see that it is coming down with a within a small period of time and here it is taking more time to come down. And proton density contrast is the difference in signal intensity between tissues of their relative number of protons per unit volume. High signal on brain tissue, bright on proton density contrast. Tissue on low proton density have low signal, example cortical bone, dark on proton density image. Proton density is the basic of MRI contrast. So here is the proton density weighted image, how it will be. So when the intensity is higher, we get high proton density and when the intensity is lower, we get low proton density. So you know that wherever there is more intensity is coming out, we get high proton density in the image and wherever there is low intensity, we will get fewer protons. So this results in the contrast of the image. So this is for easy understanding of between magnetization and saturation and excitation of RF pulse for T1 and T1 contrast. So here is TR and short T1 and long T1. The difference between the short T1 and the long T1 is what gives us the contrast. So the 67% is what is shown by this dotted line. So from one RF pulse to the next RF pulse. So for one imaging cycle, we have longitudinal magnetization and transverse magnetization. So we have seen in the previous one, and short T1, T1 and long T1, the difference between that is what is called T1 contrast, and high PD and low PD is the proton density contrast, and long T2 and short T2 is what gives rise to T2 contrast. So this is what is happening along with the magnetization, and the image brightness and the brightness between white, black, bright white, black and the gray areas is what gives us the contrast in the image. So you can see that the difference between T1 contrast, the brightness across the T1 is bigger, means there is darker areas, lighter areas and bright areas, where the contrast between low PD and high PD is in the same, means more or less in the same region. So the contrast between that is lower, and the long T2 and short T2 gives a wide range of brightness, giving rise to better contrast. Pulse sequences, applying the pulse sequences, weighting and quality is determined. So types of pulse
Ma'am,
sequences are, yes.
ma'am, so we have to always acquire imaging T2 weighted only
No,
if
no,
it
that
has
depends
better
on what
contrast.
we want to see. Depending on what we want to see. So if we have seen, no, depending on different clinical conditions, there will be like what is seen brighter in T1 contrast, what is seen brighter in T2 contrast, what we actually want to see and which will look better for the physician to identify the deformity. Accordingly, we see the T1 or T2 contrast images, or this all happens. So you can see that the magnetization takes place, and the time of the magnetization, RF pulse and the RF relaxation is what gives us all this information. So this is all acquired in the same one imaging cycle. Everything is there. So depending on what we are looking at, we will select which one to look at it. We can see the other images also correspondingly, but what we want to look at it and what will be in which mode it will be better, we will look at it at the T1 or T2 or proton density contrast phases.
Ma'am, at one
Yeah.
time we can acquire only one weighted image, na either T1 or proton density or T2.
No, no, no. This is the one imaging cycle, like when longitudinal magnetization and transverse magnetization is there, no. Longitudinal magnetization is the magnetization along the longitudinal axis, and transverse magnetization is the magnetization along the transverse axis. So when the magnetic field is applied, all the protons will get aligned to the applied magnetic field. Then we are applying the RF signal. So when the RF signal is applied, it will get disturbed. It will change according to whichever is in the same frequency with the applied RF signal, it will gain energy. And when the RF signal is off, then the whatever energy received will be going back to its original magnetization, or the magnetic field get more strength and the protons will get aligned with the initial applied magnetic field. So all these take takes place like this. All this are happening at the same time. So what we are acquiring, what we are looking at, it is based on what we needed to do. All this happens at the same time. You didn't get it.
Okay, ma'am. Yeah, ma'am, I didn't get it.
Okay, I will tell you once again. See, different things happens. So this is the longitudinal plane. This is the transverse plane. When an applied magnetic field is applied, B0 is applied, the net magnetization vector of each of these nuclei, all of these are there, no? Each nuclei is there. It has different spins which are not aligned. This is how it is when there is nothing. This is how it is there in our body. And when the patient is placed inside the field, this get aligned because of the magnetic field, and each proton has a dipole. So that dipole get aligned with the applied magnetic field. So the high energy ones will be the spin down ones and low energy ones will be the spin up ones. So this happens. Once the patient is placed inside the magnetic field, all the proton nuclei in the body gets aligned with the applied magnetic field. Then we apply the RF pulse. So when we apply the RF pulse, the frequency of the RF pulse, whichever nuclei having the same frequency as the radio frequency pulse which we applied, they will gain energy from the RF pulse. Only those nuclei which are having the same frequency will gain the energy. And when the RF pulse is over, then it will go back. Means whatever energy is gained by the nucleus will lose its energy. You are understanding?
Yes, ma'am.
So that losing of energy will depend on whatever magnetic phase it was initially, like whether it was spin up, spin down, longitudinal magnetization, transverse magnetization, what was the frequency of it, and so we get all this information from there. So how it is going back, that is the differences in going back to the initial magnetization is the T1 and T2 and proton density and all. So in simple ways, when we apply magnetic field, all the nucleuses get aligned. It may be spin up, spin down. And when we apply the RF pulse, those nuclei which are in the same frequency as the applied frequency will gain energy from the applied RF pulse. And once the RF pulse is over, these nuclei will lose its energy. So that losing of energy takes place different for fat, water, and bone, different tissues. So that is what is helping us. You have seen the table, no? Some of it takes 9-10 milliseconds, some of it take 80 seconds. So that variation is what gives us the image. So T1 is when we have seen, no?
Ma'am, my question is that
Yeah.
if we want T1 weighted, then we have to apply short TE and short TR. So at a time, we can acquire only T1 weighted image, not T2 or proton density.
No. What I am telling is acquiring is a different thing. But what happening is T1, T2, proton density, all this is happening. You are understanding what we are talking about is the acquisition. No, acquisition is a different thing.
Okay, ma'am.
So when we are applying magnetic field, it gets aligned. When we are applying RF pulse, some of it gets energy, which are in resonance with the applied RF field. And when the signal RF pulse is over, then the whatever energy is acquired, it will lose and come back in alignment with the applied magnetic field. So some whatever that variations, like how it is coming back, some will have long TR, some will have short TE. So that depends on the tissue. So our body, it is not a single tissue. No, our body has fat, our body has water, our body has different types of tissue. Brain is there, muscle is there, different types of tissues are there. So, but every proton in our body will get aligned, and everyone will get some energy from the RF pulse depending on the frequency at which the RF pulse is applied. But when the RF pulse is gone, how it will go back to the normal thing or the applied magnetic field, that varies. You understand? So
Yes, ma'am.
fat will go back in a different way, water will go back in a different way, muscle will go back in a different way. So that is
Yes,
what is
ma'am.
terminated by all these parameters. So whichever we want to look at it, depending on the clinical condition, if we want to look at small TE, then we will look at T1. If we want to look at long TR, then we will look at the T2 image. It is like that. But the process is taking, the whole thing is T1, T2, proton density, all this is happening when we are applying the magnetic field and the RF signal. So out of that, which one you need for your diagnosis? To make a valid diagnosis, that is what we are choosing the modes to acquire.
Yes, ma'am. Now understood.
Yeah. I will share the PPT, so you go through it again and again, then you will have a better idea.
Sure, ma'am.
Because it is not possible for us to, like, every slide can be discussed for one hour. So this is what it is there, no? So the applications are like that. Whichever we want, we can choose that. It's all happening. So this is one imaging cycle. The whole thing happens there. So you can see that with the different times and with different TR and different TE, what happens with respect to magnetization. So you can see that here we have dark and here we have light, and the difference between short T1 and long T1 is what gives us the T1 relaxation. And if it is happening between this, it is only T1. And if it is happening between this, then it is PD. Then if it is happening between this, it is long T2. So but this all comprises the one imaging cycle.
Yes, ma'am. Now I got it.
Yeah. And pulse sequences are applying the pulse sequences, weighting and quality is determined. So types of pulses are spin echo sequences, gradient echo sequences. So SC and GRE. Spin echo sequences are the single echo techniques: CSC, conventional spin echo; FSC, fast spin echo; IR, inversion recovery; IRM, inversion recovery magnetization; and STIR, short inversion recovery, and FLAIR, fluid attenuated inversion recovery. We will see in details in the coming class. So these are different techniques which we use to get particular information out of this process. So the spin echo pulse sequence is when the RF excitation pulse is removed, relaxation and decay occur together, and there is dephasing due to magnetic field inhomogeneities. So here you can see that the same thing, the RF relaxation is the RF excitation is removed. So the relaxation and decay occur together, and the dephasing due to magnetic field inhomogeneities. So whatever differences in the magnetic field inhomogeneities is what we are aiming at, then we have to do the spin echo pulse sequence. This inhomogeneity can be compensated for by a 180 degrees RF pulse or spin echo pulse sequence. Dephasing causes the magnetic moments to fan out in the transverse plane, and spin echo pulses help to bring these in phase. So both are in phase at starting of the race, which corresponds to the 90 degree RF pulse. So the longer the distance covered, the greater is the phase difference between the two. So as the second gunshot is fired 180 degree RF pulse, both turn around and head backwards. So you can see when they head backwards, that is also at different phases. So that runner catch up with each other and reach the start together. That is if they are in phase. If they are not in phase, they will not reach the starting point together. They will reach back in different phases only. I think I hope you got it. Like we are applying the 180 degree pulse. Forget about this spin echo pulse sequence we are applying. So when we are applying the 90 degree pulse, that is at the starting point, and depending on the characteristic of both the runner, it will go at different phases. So that is the magnetic field inhomogeneities with respect to both nuclei. And when the 180 degree pulse is applied, this will come back to the initial position if both are in the same phase. If they are dephasing, then it will be in different positions. That is what gives us the information required. And multi-echo technique, FSC is the fast echo sequence, TSC is the turbo echo sequence, rare is rapid acquisition with relaxation enhancement, haste is half Fourier acquisition, single shot turbo spin echo, and rare is rapid acquisition with relaxation enhancement. Hastrim is combination of inverse recovery with haste. So these are all techniques like where when we need to study one particular feature, we manipulate these features, our RF signal, our magnetic field, our the second pulse which we apply, all these we manipulate depending on what we need to study and what information we need to differentiate in the tissues. But the basic things which is happening is all the same. That remains the same. We are not changing the patient. We are not changing the machine. So what we are changing?
Doors will open on the left. Please mind the gap between the trees.
And gradient echo sequence is a single echo technique. So the gradient echo, coherent spoiled GRI, incoherent steady state GRI are there in the gradient echo sequence. So the techniques are FISP, fast imaging with steady precision, GRASS, gradient recalled acquisition into steady state, DES, double echo steady state, CISS, constructive interference in steady state. And snapshot flash is the fast low angle shot turbo flash. Multi-echo techniques are UFSC, ultra fast echo sequence, GRASS, gradient recalled acquisition into steady state technique, EPI echoplanar imaging, IREPI inversion recovery echoplanar imaging, DWEPI diffusion weighted echoplanar imaging, ADC apparent diffusion coefficient. And the flow phenomena, flowing nuclei exhibit different contrast in blood and CSF. So motion of nuclei causes mismapping of signals and result in artifacts or phase ghosting. So here you can see again, when we are studying flowing mediums like blood, contrast in blood and CSF, the nuclei exhibit different contrast. So motion of nuclei causes mismapping of signals and result in artifacts or phase ghosting. This cause of artifacts known as flow phenomena. In order to produce signal, nuclei must receive an excitation pulse and rephasing pulse. The flowing nuclei present in the slice for excitation. This is called the time of flight phenomena. So time of flight phenomena. So the flowing nucleus, it is moving, and if it is not excited, so the excited nuclei flows and it when the rephasing happens, and when the excited nuclei goes beyond, it is not rephased if no signal is given. So here you can see that if the flowing nuclei is excited, it gets rephased and gives us a signal. And if the flowing nucleus is excited but not rephased with the second signal, then there will be no signal. And if not excited and if it is rephased, it will not give any signal. So this is the RF pulse which we are giving, the 90-degree pulse and 180-degree pulse. So with 90-degree pulse, the nuclei get excited, and at 180-degree pulse, it gets rephased. We will get a resultant signal. If at 90-degree it gets excited, but at 180-degree it doesn't get rephased, we will not get a signal. And at the not excited, and then if at 180-degree, if it gets rephased, then also we will not get a signal. So that is how we get the information out of the system, depending on the different clinical situations or anatomical or physiological parameters. Time of flight depends on type of pulse sequences, result in signal void from the nuclei. Vessels appear dark. It depends upon the velocity of flow, TE, slice thickness, velocity increases, time of flight increases, velocity decreases, time of flight decreases. TE longer the TE, more nuclei are reviewed, and slice thickness, contrast velocity take longer time to travel through thick slice. So thickness of slice decreases, signal void increases. Flow phenomena compensation should be compensated. So adverse effect in image can be minimized by compensation. So not all features, not all physical things or the physiological things happens in the under the influence of the magnetization is not favorable for the reasonable imaging. So some of them needs to be compensated, some of them needs to be enhanced to get better imaging. So flow phenomena compensation should be compensated so the adverse effects in the image can be minimized. Pre-saturation nulling the signal from flowing nuclei, so effects of entry slice and the time of flight phenomena are minimized. Pre-saturation for arterial flow from the above. For venous flow from the below is saturated, uses of pre-saturation. Coronal imaging of chest saturation from the subclavian vessels. Other uses, fat and water saturation, reduce the aliasing. Image formation in MRI. Scanner acquires high and low signals from the patient. Patient is positioned in the magnet. RF is applied. Magnetization occurs. MR signal is produced. The signals are converted to electrical signals and digitized. Signals are stored in a space known as K space, where the newly acquired data are stored in pre-imaging time. So the K space is known as the frequency domain space. When K space is filled, the FT algorithm, Fourier transform algorithm, uses the data to reconstruct the images. These are displayed in the monitor where the images can be manipulated by using special processing software, windowing, 3D images, MIP, etc. So this is what you were asking about. So we get all the information, and from whatever we need, we process accordingly. So voxel is the three-dimensional of a pixel, and the pixel has a matrix arranged in rows and columns. So here the information is there, to what extent the relaxation, the what extent the magnetization took place. That information is stored in, with respect to each nuclei, is stored in the pixel displays. So slow relaxing tissue will be darker and fast tissues will be whiter, medium tissues will be gray, gray or the lighter color. So this is how we get the T1 image. So the frequency and phase with respect to RF signal. So each of this will be stored in each of the matrix spaces in the K space. And then we can color code them with respect to the signal intensity on the gray scale or any scale. So this is in nutshell what happens in image formation in MRI. The MR scanner is there, composite MR signals from all voxels within the slice, and spatial frequency domain, K-space, digitized spatial frequency data. So this is the MR signal acquisition. And once this signal acquisition is done, we use the image reconstruction techniques to get the spatial location and we get a understandable image for us. We can visually understand. So this information, whatever densities are there, whichever direction, how much ever relaxation happens, how much ever recovery happened, all these are stored in the K space. So using the Fourier transform, we convert it into an image which can be understood by us. So this is again the same thing which we have seen in the previous classes. So the MRI signal magnetic gradient coils, radio frequency coils are there, the gradient power supply. So you can see that the radio frequency transmitter gets the radio frequency transmitter and the gradient power supply both gets the input signals from the computer. And once the image acquisition is done, the radio frequency receiver receives the signal and feeds it into the computer. So we have both the input information and the output information, and from where the image reconstruction is taken place to get the readable image. And Fourier transformation is the image There are other image reconstruction modalities also. Fourier transformation is the basic one which we utilize. So as we have better computers, better better calculational system, better imaging parameters, we can use other mathematical models also to get even finer details to be perceptive from the data we acquired. And voxels and pixels, the three-dimensional space is called a voxel and the two-dimensional space of a matrix is a pixel. And computer analysis and image reconstruction takes place and the result is displayed as a grayscale, and window level and window width is there. At what level and how much broad each window is, that again helps us to have a contrast image or distinguish between different things as different. As the result of resonance, the net magnetization vector in phase in transverse plane, as the NMV precesses at the Lambda frequency in transverse plane, voltage is induced in the coil. Those voltage constitute MR signal. Frequency of the signal is the same as the Lambda frequency of that magnet. First it locate the slice is selected, signal is located or encoded in both axes. Tasks are performed by gradients. 3 gradients coils situated, Z gradient long axis of the magnet, Y gradient vertical axis of the magnet, and X gradient is the horizontal axis of the magnet. So this we have seen in the last classes. So the magnetic resonance image quality characteristics. So the spatial artifacts, detail, contrast, noise, all these things helps in are incorporated in the imaging protocol. Spatial information, details, contrast sensitivity, artifacts, and noise. So we have information according to the TR and TE and the matrices in which the information is saved. And protocol factors affecting image detail and image noise. So image details are affected by slice thickness, matrix slice, and field of view. And image noise is affected by slice thickness, matrix size, field of view, coil selection, averaging, bandwidth, TR and TE, field strength. And artifacts in MR imaging are unusual signal intensity. All images have artifacts in MRI to some degree. It is very important to understand causes of artifact. Phase mismapping can, aliasing can, chemical shift can, chemical misregistration can, truncation, zipper, shading, motional, cross-excitation, all these can result in the image artifacts. Phase mismapping or ghosting, anatomy moving along the gradient during pulse sequence, that is chest, expiration and inspiration, reduces by pre-saturation. Gating motion caused by cardiac motion, pulsatile flow, etc. are to account for the mismapping or the artifacts produced because of the natural physiological phenomena, like the phase mismapping normally happens with expiration and inspiration, the breathing, the chest moves. So all this can, the movement can cause artifacts. So this can be reduced by pre-saturation, or the cardiac motion, the heart inside is moving on its own. So that motion can be accounted by gating. We can connect to the ECG and the ECG can be gated to the image acquisition. So when the heart is expanded, when the heart is constricted, that information we can get, and it can be correlated with the images which we received. So this can be utilized to pre-saturate. The effect of motion can be eliminated by different techniques. And aliasing is an artifact produced by anatomy that exists outside of the field of view, which is mapped inside the field of view. And chemical shift caused by different chemical environment of fat and water, as fat and water persist difference. Fat consists of hydrogen linked to carbon and water hydrogen linked to oxygen. Fat persists lower than water. Difference in positional frequency is 220 Hz, reducing chemical shift. So scanning with low field strength, keep the FOV minimum. All these are methods to reduce the chemical shift artifacts. And chemical mismapping, it is also precisional frequency difference between fat and water. Signal of fat and water out of phase, they cancel each other out. So as a result, signal is lost, cause dark ring around the structures. So remedy is used FSC pulse sequences and T matches periodically to F and W, fat and water. Truncation, during sampling of data that results of high and low, signal which are incorrectly represented in the image is known as truncation. T1 image of C-spine, Gibbs artifacts, etc. are examples of truncation artifacts. And correction is sampling data must be correction. Magnetic susceptibility artifact, ability of a substance to become magnetized. Some substances magnetize to difference, as a result signal loss. Example, metal ion content, hemorrhage. So the advice is use diagnosis of hemorrhage. And zipper artifacts, appear dense lines on the images at a specific point or line. It is caused by leak of RF shielding of the room. Remedy, call the engineer, locate the leak and repair it. And motion artifact, any motion of the patient causes the motional artifact. So this can be divided into involuntary and voluntary. So twitching, pulsation, bowel motion, etc. are involuntary. Voluntary are swallowing and the motion due to nervousness of the patient. Correction for bowel motion, antispasmodic IV prior to the scan, and pulsation pre-saturation gating, and voluntary motion, making the patient comfortable and give proper instructions. And in extreme cases, like if the patient is mentally disturbed or if it is a child, then sedation can be used. And cross excitation, RF pulse not exactly the square. Adjacent slices receive energy from RF excitation of their neighbors. Overlapping of energy can be reduced by 30% gap between the slices. Shading, loss of signal intensity in one part of image, uneven excitation of nuclei, abnormal loading on coil, coupling of coil at one point, inhomogeneity in the applied magnetic field. Remedy, load the coil correctly, patient not touching the coil, appropriate scan parameters are selected. Contrast media in MRI, contrast agents are those substances which differentiate the tissues, either increasing or decreasing the signal intensities. Contrast agent shorten T1 or T2 time of surrounding photons, result in T1 weighted and T2 weighted images. Indication of MR contrast agents, we have seen it, but just in a nutshell, used to differentiate tissue structures, the tumors in the various organs and tissues, detect metastasis in brain, small acquisition neuromas, microadenoma in pituitary, neurocysticercosis, granuloma, tuberculoma, hemangioma, etc. Pathologies of spinal cord, head and neck, musculoskeletal, etc. Mechanism of contrast action is works by altering the tissue relaxation rates. MR imaging signal intensity depends on a combination of different factors. So we have seen this proton density, T1 and T2 relaxation time, diffusion, perfusion. So these things can be altered to get more information where there are less differences. So classification of MRCA, T1 agent positive and T2 agent negative. And T1 agent, paramagnetic substances which affects the T1 relaxation called positive agents. Lanthanide groups of metal have strong paramagnetic effects due to unpaired electrons. Gadolinium, most potent reflexivity agent. Other metals are iron, dysprosium, manganese. Gadolinium based contrast agents We have seen this, and gadopentate dimerglobin, the trade name Magnavist, and we have gadolinium DTPA, BMA, gadodiamide, and gadopentate and gadotetrate, GD dota, dotarum, etc. So we have seen in detail in the last class. And T2 agents affects the T2 relaxation rate, results in reducing the signal intensity in T2 weighted images. The ferromagnetic and superparamagnetic substances little effect on tissue relaxivity. It is studied as negative contrast agent. It decreases the signal intensity in T2 weighted images. DTPA, G chelates can also used as T2 agents. Dose of MR contrast agent usually in this range, and maximum total dose is in 20 ml. Route of administration can be oral or IV. Adverse effects, feeling warmth, pain at the injection site, seizures, strange taste, nausea, headache, dizziness, shortness of breath. Anaphylactoid reaction may occur. So I think, yeah, that is the last slice. So these are the basic, the initial slides are the basic principle. You go through it again and again and understand it in your own terms. And if you need further, you read some textbook. You can read Christensen, you can read John Boone. The MRI part, things are given nicely in the Boone, Bushberg book and the Christensen. So make the fundamentals clear, like you will have a nice idea about how the X-ray imaging done. So similar things are happening here, you based on different physical principles. So understand that physical principles and correlate it with the whatever you are reading. So this everyone needs to understand in their own terms. Okay, that concludes today's. Please share with me the attendance. You can share it in the group and I will send the PPT.
Sure,